Hello everyone, welcome back to another video. This is Karim again, and in this video we'll discuss search high yield concept in the renal system in step 1. Hope this video becomes helpful for someone out there. The first important concept is that when they tell you that we give a person a drug from the ones in the list here, and then this person developed a rash, you start to think about a hypersensitivity reaction. But then when they add that this person is also having renal damage or eosinophils in the urine, for example, then you think about a hypersensitivity reaction in the kidney itself, which is acute interstitial nephritis. It's a type 4 hypersensitivity, meaning it's made by T cells or acute cellular reaction. And you need to differentiate it from when they tell you we give the person a drug, then he developed a muddy brown cast. Either a drug or contrast. For example, we did CT scan with contrast, then he developed a muddy brown cast, or a very high kidney damage, for example, and the sodium excretion was more than 2%. Then it's acute tubular necrosis. Okay, it can be caused by aminoglycosides, amphotericin B, or cisplatin or platinum drugs. But the most important one is non-steroidals, because non-steroidals can cause three kidney problems. It can cause acute interstitial nephritis, it can cause acute tubular necrosis, it can also cause renal papillary necrosis. So depending on the keyword, you will answer the question usually. The third concept is that nephrotic will usually cause fatty casts with protein in the urine. On the other hand, the nephritics can also cause protein in the urine, but with RBC casts. And this is very important, is that a lot of students confuse them together. Both of them can cause protein in the urine. And it will not be that helpful to know the range. But what's helpful is that nephritic will always present with RBC casts. Nephrotic will never has this RBC casts. Okay? Now, when you see a kid with proteinuria, so you know it's nephrotic and he's having a periorbital edema because he is losing albumin, so the oncotic pressure is decreasing. This is usually minimally changed disease, and you need to give steroids as first line of treatment because it has something to do with inflammation. Now, a very important is that they ask you what would you see in the microscopy, and you have to really look what they're asking about. Are they asking light microscopy or electron microscopy? If it's light microscopy, it's not that accurate or not that magnifying, so you will see nothing at all, so you will see no change, and this is how I remember it's called the minimally change. So the only change you will see is only if you use electron microscopy, then you will see effacements of podocytes, as you can see here, this is normal podocytes, and this is the effacements that can happen in a person with minimally changed disease, okay? Now, another concept is you see a kid with blood in the urine, RBCs casts, so you know it's nephritic. Then they give you a history of an infection. You need really to look at the timeline. If this infection was an upper respiratory tract infection 1 or 2 days ago, or if it happened before, so it was episodic, then it's IgA nephritis. On the other hand, if you see a person having a sore throat or skin infection like impetigo, then he got this blood in the urine 2 to 3 weeks afterwards, then this is usually post-streptococcal glomerulonephritis. Now I need you to differentiate post-strep from rheumatic fever. Both of them can be caused by strep, but rheumatic fever is usually type 2, meaning autoantibodies attacking our body, thinking that or confusing it with the strep infection. This is called the molecular mimicry. Our molecules looks like the immune protein in the strep, so it's get attacked instead of the infection itself. This is called type 2. But on the other hand, post-streptococcal glomerulonephritis is type 3, meaning the antibodies bind to the complement, both of them will deposit with the urine, deposit in the kidney, and cause kidney damage. Okay. Now, the second concept is nephrotic in adults. The most important two are membranous and focal segmental, and the only way to differentiate between them is really the risk factors. Membranous, think about solid malignancy, like lung cancer, think about infections like hepatitis B, think about drugs like penicillamine and gold, and think about Caucasians and Asians. But on the other hand, the focal segmental, I remember the F and S for African American F and sickle cell disease. It's also associated with obesity, with HIV, and with heroin. Remember, hepatitis B is membranous, but heroin and HIV is usually focal segmental. Hepatitis C, on the other hand, is membranoproliferative. Remember, the C is bigger than the B. So B membranous, but C membranoproliferative. Okay. Um, the next concept is when they tell you something about glomerular basement membrane. We have two diseases that affect the glomerular basement membrane. The first disease is an autoimmune, so it happens in adults, and it's an antibodies against the glomerular basement membrane or against type 4 collagen in general. And usually it affects the lung and the kidneys. And this is called goodpasture syndrome. You will see hemoptysis and hematuria in an adult, and it's usually antibodies against the glomerular basement membrane. These antibodies will deposit in a linear fashion like this, and this is called the linear deposition. On the other hand, if you see a boy, and the reason I'm saying a boy because this disease is inherited, so you see it in kids, and it's an X-linked, so you see it in boys more. And they tell you this mnemonic can't see, eye problem, can't pee, lung, kidney problem, and can't hear a bee, ear problem. This is usually Alport syndrome. Alport syndrome is an inherited deficiency in type 4 collagen, not an antibodies, and that's why it happens in kids. So take care of these two diseases and don't confuse them together. Now, platinum drugs, aminoglycosides, and the loop diuretics, especially isacrinic acids. This is the one that we use in sulfa allergic patients because they cannot use the normal other loop diuretics. These ones can affect both the kidneys and the ears. So it's similar to Albert, affects the kidneys and the ears. And it's very important to remember these ones. And honestly, these are the ones that I see that show up a lot in the exam itself. The second concept, for some reason, students confuse it. Renal tubular acidosis is a cause of a normal anion gap metabolic acidosis. It never causes a high anion gap. So when you see this person with acidosis and they ask you what's the most likely cause, and it's a normal anion gap, and then the answer choices they give you uremia, DKA, iron, and renal tubular acidosis, don't hesitate to choose renal tubular acidosis. People somehow think that it causes high anion gap, but it's actually not true. Now, the thiazide adverse effects are important. It can cause increase in glucose, hyperglycemia, hyperlipidemia, hyperuricemia, don't use it in gout, and hypercalcemia. But the way it causes hypercalcemia is that it absorbs the calcium from the urine to the serum. So it's actually important that we love to use it in kidney stones, not the other way around. So sometimes we use thiazide in kidney stones. When you see a person with diabetes and the proteinuria, especially albuminuria, you give ACE inhibitors because ACE inhibitors will decrease the glomerular filtration rate. And the problem with diabetic patient is that he is filtrating too much protein, and this too much protein that's being filtrated is affecting the kidney. So when you give ACE inhibitors, you decrease the GFR by uh, dilating the efferent and causing most of the urine to bypass the glomeruli. You will then protect this person from progressing to end-stage renal disease. Fun fact is that ACE inhibitor also cause cardioprotection. It decreases the cardiac remodeling after myocardial infarction, and it has mortality benefits. Other drugs that can have mortality benefits are aspirin, statin, beta blockers, potassium-sparing diuretics, and SGLT2 inhibitors. If you see a colicky veins that radiates to loin or groin, think about kidney stone. And if they didn't give you a specific keyword, usually it's calcium oxalate because this is the most likely cause. And the treatment is simple, just hydration, too much water. This is all the abdominal pelvic regions. Let's go through them very fast. If you see epigastric pain, usually it can be caused by pancreatitis or peptic ulcer or abdominal problems. If you see umbilical, it can be an early appendicitis that can radiate to the right lower quadrant uh, and can cause right lower quadrant pain. But take care if it's a girl, you need to differentiate, is it appendicitis or is it ectopic pregnancy? So you need to do an HCG test, okay? If you see an old person with left lower quadrant pain and the fever and the leukocytosis, this is usually diverticulitis. If you see right upper quadrant, it's usually gallbladder stone. If you see left upper quadrant, it's usually splenic abscess, can happen in endocarditis. And if you see costovertebral angle tenderness, then it's pyelonephritis or renal cell carcinoma. And if you see suprapubic tenderness, usually it's the urinary bladder, so it's usually cystitis, for example. Now, if they give you some keywords, you need to take care. For example, if they told you this kidney stone in kids, then it means it's an inherited condition, which is cystine kidney stones. In this disease, you cannot absorb cystine along with other amino acids, cola, and you will have the cystine in the urine too much. They will bind to each other and they will cause cystine kidney stone. Remember, cystine 16, so it has this six shapes, exogenal in shape, as you can see in the picture, and the teens, so it happens in teens or happens in kids. If you see a stone with a urinary tract infection, it's a strovite kidney stone. It's a very large kidney stone. If you see it, you will be shocked. Sometimes we need surgery to remove it, and it's caused by Proteus. And another causative organism is Klebsiella. But if you see both of them in the answer choices, you go with Proteus. Uric acid is usually radiolucent, meaning it will not appear on the on the X-ray, and it's rhomboid in shape. Rhomboid in shape. And the way you treat it is by alkalinizing the urine. It's an acid, so alkalinize the urine and it will be easily excreted. The next concept is that horseshoe kidney is associated with Turner syndrome. And the problem with horseshoe kidney is that usually our kidneys are formed in the pelvis and then they ascend. Because these kidneys are connected together, when they try to ascend, they will be blocked by the inferior mesenteric artery. And when they get blocked by the inferior mesenteric artery, then they will fail to ascend and they will stay downward. Usually the person will be asymptomatic, but they love to ask about is this artery. They will tell you which artery prevents the ascension. The next concept is that the superior mesenteric artery here can compress the renal vein. It's called nutcracker syndrome, and this can cause varicocele. Also, if there is renal cell carcinoma, it can infiltrate the renal vein and also cause varicocele. So varicocele on the left side can be a sign of malignancy. Congenitally, we have three kidneys: pronephron, mesonephron, and metanephron. The ones that usually stay with us until adulthood is the metanephron. And I remember meta with T is the permanent kidney. It will form the glomeruli until the distal convoluted tubules. So glomeruli, proximal, and ascending limb, and the descending limb. Then the distal. Then it will combine with the ureteric bud. And the ureteric bud usually forms the collecting ducts and the ureters, and they will fuse together. Sometimes they will tell you if the person is having renal agenesis, what's the cause, and the answer is failure to fuse the ureteric bud with the metanephron or metanephric blastema. Now, if you have renal agenesis, what happens is that you cannot pee, and if you cannot urinate or pee, then what will happen is that you will have too little amniotic fluids. If you have too little amniotic fluids, you cannot exercise your lung and your lung will be compressed. So you will have pulmonary hypoplasia. Also, you cannot protect your limbs from the outside, so the baby will have limb deformities. Deformities, not malformation. Deformities meaning something from outside is deforming this baby. And it's very important that it's called Potter sequence, not syndrome and not association. Sequence meaning something is causing the other one. For example, we start with renal agenesis, then you will have oligohydramnios, then this oligohydramnios will cause the pulmonary hypoplasia and the limb deformities. Now, if you see a person with abdominal mass in the right or on the left, and hematuria and abdominal pain, and he is a smoker, then think about renal cell carcinoma. It's called the clear cell renal cell carcinoma because, as you can see, the cells are clear like the lipids because they are filled with lipids, and they can secrete erythropoietin. It's very easy to remember because the kidney itself secretes erythropoietin, and it can also secrete parathyroid hormone-related peptides and increase the calcium level. Now, it can be associated with a syndrome called von Hippel-Lindau, and I remember it by three characters. So VHL, chromosome 3, renal cell carcinoma, hemangioblastoma in the brain and the eye and the spine, and also it can cause pheochromocytoma. The next concept is kidney disease and the kidney cysts. So if you see an autosomal dominant polycystic kidney disease. Think about AD, autosomal dominant, adults. It happens in adults, and it will cause cysts everywhere. So cysts in the brain, so it can cause perianeurysm and subarachnoid hemorrhage. They will tell you he is having his worst headache in his life. And it can also cause cysts in the heart, so it can cause mitral valve prolapse, and the cysts in the kidney and cysts in the liver. On the other hand, autosomal recessive polycystic kidney disease is a problem in a gene called fibrocystine. It happens in kids, and I remember fibrosis in the liver, cystine, cysts in the kidney. This is how I remember both of them. Loop diuretics will cause metabolic alkalosis and hypokalemia. On the other hand, spironolactone will cause metabolic acidosis and hyperkalemia. Not only spironolactone, but really any drugs that can work on the renin-angiotensin system. Spironolactone can also cause gynecomastia, similar to ketoconazole and cimetidine. And the reason for this is that remember that aldosterone is secreted from the adrenal gland, similar to androgen. So sometimes spironolactone will inhibit androgen instead of inhibiting aldosterone, and it will cause the androgen to decrease. So estrogen will be increasing in the ratio, and you will have this gynecomastia in males. If you see polyuria and it's not diabetes, usually it's either diabetes insipidus or psychogenic polydipsia. If they told you when we stop him from water or when we prevent water from him and the problem is not solved, usually it's diabetes insipidus, meaning ADH is not working, so ADH is not absorbing water, so all the water is dropped down into the urine. And this can be caused by two factors. Either ADH is not secreted, meaning that the posterior pituitary is having this problem, or the hypothalamus itself, or the ADH is secreted but it's not working, and this usually happens in nephrogenic diabetes insipidus. Now, if you see on the other hand that the person is having a diluted urine and diluted serum, it means he is drinking too much water, and when he drinks too much water, he dilutes his blood and he dilutes his urine. So this is primary polydipsia. It's very easy to answer it on the exam because they will tell you when we do a water deprivation test, the urine osmolarity will increase. The urine osmolarity will increase. Now, inversely, if you see diluted serum but concentrated urine, it means that ADH is working too much, so it's absorbing water from the urine and into the serum, so it's diluting the serum and causing hyponatremia. This is called syndrome of inappropriate antidiuretic hormone because antidiuretic hormone is secreted inappropriately. It can happen either in drugs or in some cancers. The most important drugs are carbamazepine, which is an anti-epileptic, and the SSRIs. The most important cancers is usually small cell lung cancer. Remember, small cell lung cancer will cause SIADH. It can also cause Cushing syndrome, and it can cause Lambert-Eaton. On the other hand, squamous cell will cause parathyroid hormone-related peptide increase. If you see a kid with abdominal mass, think about cancer. If the mass doesn't cross the midline, it means it's in the kidneys, so it's Wilms tumor. But if the mass crosses the midline and the boy is less than 2 years of age, usually it's neuroblastoma. When you see dry cough and angioedema caused by ACE inhibitor, you need to switch to angiotensin receptor blockers as fast as possible. And the reason ACE inhibitors will cause dry cough and angioedema is that it inhibits the angiotensin converting enzyme, which usually is used to get rid of bradykinin. So when you inhibit it, you cannot get rid of bradykinin. Bradykinin will accumulate, and it can cause this dry cough and angioedema. ARBs, on the other hand, has nothing to do with inhibiting the ACE. It just blocks the angiotensin receptor itself, so it will not cause this problem. Now, another important cause for angioedema is C1 esterase inhibitor deficiency, and it's an inherited disease, and they will usually describe it as a family history. The most common cause of urinary tract infection is E. coli. I would say all of all of you know this, but it's also important that even in young females that are sexually active, it's still E. coli. Saprophytic is a specific, but it's not the most common cause in young females. So unless they tell you that it's nitrate negative or gram-positive cocci, don't pick saprophyticus. Or unless you don't see E. coli in the answer choices, then you would pick saprophyticus. Another important drug is acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. It works on the proximal convoluted tubules and it can cause metabolic acidosis. And it can be used in high altitudes. The reason for this is that when you go into high altitudes, you are having less oxygen as you go up. And when you have less oxygen, you will start to respirate too much to use the enough oxygen in the air. When you respirate too much, you will get CO2 out of your lung. When the CO2 is getting out of your lung, you are having respiratory alkalosis. Remember, CO2 is acid. So if it's low, then you are having respiratory alkalosis. And when you have respiratory alkalosis, you need to compensate. How would you compensate? You compensate by metabolic acidosis. Now remember that metabolic acidosis compensation, it takes 1 day to happen. And sometimes we need it to happen faster. So we will give acetazolamide to cause this artificial metabolic acidosis and help us with high altitudes. We can also use it intravenously to decrease the intraocular pressure in acute angle-closure glaucoma. Now, another important concept they love to ask about it is that the proximal convoluted tubule is the most important part in the kidney that use ATP. It's also the part that renal cell carcinoma originate from. The last concept is that if you see dysuria, think about UTI, of course. If it's associated with fever and costovertebral angle tenderness, then it's a kidney. But if it's associated with suprapubic tenderness with no fever, then it's cystitis. That's it. Thank you guys. Much love. I will upload the PDFs and the PowerPoints in the website, and I will try to publish more in the next few days. I will just having some free days because I was taking my step to exam. Bye bye and see you in the next video.